So this is, I'm talking about today anacetrapib. It is a novel CETP inhibitor. And just a second, again, my slides are. I cannot see my slides actually. One second. Now can you, now the slides are seen as right, okay?
We can see your slide, ma'am.
Okay, so I'll be talking about anacetrapib, a novel CETP inhibitor, as a potential cardioprotective strategy. Now, when we are talking about the cardiovascular disease, we know that it is one of the leading causes of morbidity and mortality worldwide. And we know that and many patients, epidemiological data shows that cardiovascular benefit from higher HDL levels is independent of the benefit associated with lower LDL levels. And we know that many patients remain at risk for future cardiovascular events despite the treatment with statins. So when we are talking about CETP, now it is a plasma protein that facilitates the transfer of cholesterol and triglycerides between various lipoprotein fractions and is a promising option. Now, when we see among the HDL increasing drugs, we know that niacin has the largest effect on raising the HDL cholesterol, but there are lots of problems like flushing and all, and there are some enzymes additions to that which can stop that, but still it has not shown much difference in the mortality. Now, when we talk about CETP inhibitors, we know that torcetrapib was one of the first which was discontinued because there was an increase in the mortality, which was in the ILLUMINATE study. And there were many reasons for that. There was an increase in the plasma aldosterone levels, which led to the increased mortality. Sodium and bicarbonate levels increased, and there was a reduction in the potassium. Now, then came dalcetrapib, which was a less potent inhibitor, and it was also compared with anacetrapib. Now, today we are talking about anacetrapib. Now, if you review the literature, there are quite a huge number of studies available with anacetrapib. Now, it has basically been studied for primary hypercholesterolemia and mixed hyperlipidemia. Now, the doses which have been tried have ranged from 20 mg to 200 to 300 mg. But in the latest trial, they have used a dose of around 100 mg because what they have found is that doses above 200 mg did not lead to any incremental increase in the effect on lipids. Now, if you see the comparative, this is slide showing the properties of the different CETP inhibitors. If you see the torcetrapib, the dalcetrapib, the evacetrapib, and the anacetrapib, and the latest one is the TA8995. That's the latest one. Now, when we are talking about the anacetrapib, now we know that one thing which we have to note here is that it has a terminal half-life of around more than 1 year, because it gets deposited in the adipose tissue. So the effects remain for a very long period. And if you see the comparative data of the increase in the HDL with these 4 drugs, torcetrapib, dalcetrapib, evacetrapib, and anacetrapib, with anacetrapib, it's around 130% increase. And the LDL reduction is to the tune of 25%, which is almost comparable with dalcetrapib, which was of low efficacy, it was 0%. But if you see with anacetrapib, it reduces the LDL by 25% and increases the HDL by 130%. And the blood pressure has not got any effect with it, because the important thing, as I told you, the main problem which came in the ILLUMINATE trial with the torcetrapib was that it caused an increase in the blood pressure because of the hyperaldosteronism, which also led to hypokalemia. So that led to the increase in the mortality and actually no reduction. if you see the data with the anacetrapib, which I'm going to show in the further slides, there was a 9% reduction in the CV events. Now, what we are discussing is the mortality, but the mortality reduction was though not seen, but there was a reduction in the CV events. And if you see the latest, which is the TA8995, which is also under study, as of now, the reduction in the CV events is unknown with it. Now, how does CETP inhibition affect the HDL function? Now we know that when we talk about the CETP inhibition, we know if you see the actions of the HDL, it has an action on, it has an antioxidant action, endothelial function action. It has a good action on the endothelial dysfunction, antithrombotic, anti-apoptotic, improves the beta cell function. It has an anti-inflammatory action, and very important, cholesterol efflux through the reverse cholesterol transport. Now, when we talk about the CETP inhibition, what happens? So actually what happens that this cholesterol efflux and the reverse cholesterol transport and the anti-inflammatory action is further exacerbated, if you see, and other actions don't have much of the effect. Now, if you see, HDL has a good effect on the endothelial dysfunction, but if you see some of the studies with the previous CETP inhibitors, they actually caused more of endothelial dysfunction. But when they were studied in mice, what they found that though there was an endothelial dysfunction, there was an angiogenesis which happened. So maybe the effect was negated to some extent. But if you talk about anacetrapib in particular, it has a good anti-inflammatory effect as well as it helps in the cholesterol efflux through the reverse cholesterol transport. Now, if you see this slide, this is about anacetrapib. It's a selective, potent, reversible CETP inhibitor. But as I showed you, it remains in the adipose tissue for more than 1 year. It's a long action. It does not have an effect on the blood pressure, meaning to say it does not increase the blood pressure because the previous CETP inhibitors have been found to increase the blood pressure. And it was the dose they have tried to use is around the dose of 300, but in the later studies, they have used 100 mg because above 200 they found was not increasing the efficacy much. And this is the slide that shows that where the CETP inhibition works. So it has an effect also on the reverse cholesterol transport, and it actually increases the reverse cholesterol transport, which helps in reducing the morbidity to some extent, reducing the cardiovascular events. Now, if you see, this is how the mechanism is. If you see, this slide shows that where the different drugs can act. So we are, as of now, focusing on the CETP. So if you see that there are different ways where the drugs can act and cause the changes in the cholesterol levels, and this acts on the reverse cholesterol transport. It has an action on the, it has an anti-inflammatory action also, and through this reverse cholesterol transport, finally the cholesterol is excreted through the feces. So this is actually potentiated by this drug. Now, if you see this comprehensive study of CETP inhibitors and cholesterol metabolism, this is not very easy to do because there are multiple mechanisms on which it works. One I told you, macrophage to feces reverse cholesterol transport. Then they have tried to see this in hamsters, where I told you that they have seen that there is an increase in the angiogenesis. So maybe that endothelial dysfunction, which has been shown to be happening because of the CETP inhibitors, could be negated. And then they have tried to see the change in the bulk cholesterol pools through high resolution mass spectrometry. And they have also tried to see the HDL functionality with ex vivo methods as well. Now, this is important. Now, if you see, the anacetrapib increases the macrophage to feces reverse cholesterol transport in hamsters. And it has been seen that there is an increase in the macrophage derived the H3 tracer in the HDL, which suggests that actually it works by increasing the cholesterol efflux from the macrophages. And finally, what effect it does have is it has, in a way, anti-atherogenic. It helps in the anti-atherogenic process. So because this is an important pathway for anti-atherogenesis, so this is one of the mechanisms by which it causes anti-atherogenesis. So if you see, it increases the cholesterol in large HDL and promotes the excretion of the bulk cholesterol. So if you see, the increase in cholesterol is greatest in the large HDL, that is the HDL2. And beyond the macrophage to feces reverse cholesterol transport, anacetrapib also increases the fecal cholesterol and the bile acid concentration. So in a way, it helps in the removing the cholesterol. And these results indicate that it could be helpful to move the cholesterol out of the system, that is from periphery to the feces, that is the reverse cholesterol transport, and also in the bulk cholesterol excretion. Now, if you talk about HDL functionality or the cholesterol efflux, so in addition to the aqueous passive diffusion, cholesterol efflux to HDL via protein facilitated pathways also happen. And In the ex vivo methods, people have tried to apply the serum from treated animals and assess the functional properties. So these are the ways by which people have tried to see how this cholesterol efflux and its effect on the HDL functionality helps and how it makes the cholesterol levels better. So here they have tried to see the plasma from the anacetrapib treated hamsters, where they found that there was an improvement in the cholesterol efflux. And both major pathways of cholesterol efflux, that is the alpha HDL and the pre-beta HDL, are increased with anacetrapib treatment. There was increase in the ABCA1 mediated efflux, which suggests there is an increase in the pre-beta HDL component. And there was an increase in the ABCG1, which indicated that there was an increased efflux to alpha HDL. And they have observed the similar things from anacetrapib treated humans as well. So the same thing has been shown in humans as well. Now, if you see the plasma from anacetrapib treated humans, it displays the improved cholesterol efflux, and they have seen that the increase in the efflux at the same HDL concentrations suggests that there's an improvement in the quality also. We know that it increases the HDL levels, but it also has been shown to improve the HDL quality as well. So if you see the HDL from anacetrapib treated humans, it maintains the ability to inhibit the TNF alpha induced inflammation in the endothelial cells. It has been seen that HDL suppresses the TNF induced addition molecule expression, and the HDL from that is anacetrapib treated hamsters showed no reduction in this effect, and monocyte addition to endothelial cells was suppressed by HDL. So basically what it suggests that HDL functionality is improved, but at least not reduced with anacetrapib, because there was a thing that whether it is reduced, but it was not. Now, when we talk of this is in a gist about the mechanisms of anacetrapib. If we talk about the mechanism of anacetrapib related low density lipoprotein, how it works, how the basic mechanisms are, how it reduces the low density lipoprotein, because we know it increases the HDL and reduces the LDL. So what they have seen that there is a reduced transfer of cholesterol from HDL to LDL particles. Compositional LDL changes, that means increased TRG and particle size, because we know the small dense LDL is more atherogenic. Decreased CATB independent PCSK9 levels, increases the LDL receptors activity, decreased drug associated hepatic cellular cholesterol transport through the CETB inhibition, and increased synthesis of LDL receptors. So finally, it leads to decrease in the LDL cholesterol concentration. So when we see there's a reduced transfer of cholesterol from HDL to LDL, that's why the HDL levels go up and the LDL comes down. Small dense LDL is less. There's a decreased drug associated hepatic cellular transport and reduced expression of the receptors, as increased LDL receptor activity as well, and increased catabolism also happens for the LDL particles, finally leading to decreased LDL cholesterol concentrations. Now, if you talk about the mechanisms of the anacetrapib mediated reduction of the triglycerides, now what we see is that there's a decreased CETB independent PCSK9 levels, increased ApoE levels, increased ApoE levels in VLDL particles because of the redistribution, and larger triglyceride rich VLDL particles depleted of cholesterol due to decreased transfer of cholesterol esters to VLDL particles, and increased serum ApoC2 and C3 levels, and decreased ApoC3 levels in VLDL particles due to redistribution, leading to better catabolism of these particles through lipoprotein lipase, better catabolism of VLDL and remnant lipoproteins through hepatic receptors, and leading to decreased triglyceride levels. Now, if we talk about the mechanisms of anacetrapib mediated increased or changes in the HDL metabolism, so there's an inhibition of CETP, that is the mechanism, decreased cholesterol transfer from HDL particles to ApoB containing lipoproteins. So increase in the HDL cholesterol and decreased triglyceride concentration on the HDL particles, increase large alpha-1 HDL particles, that is the HDL2 with increased ApoA1 levels, so the alpha-1 HDL particles increase, decreased catabolism of ApoA1 and CETB, and increased pre-beta ApoA1 HDL particles, and increased ApoA2 levels maybe because of the decreased catabolism. These are the mechanisms postulated. Now, if we talk about effects on the lipid parameters versus placebo, now this is what we studied till now, the mechanisms, because we need to understand the mechanisms, then only we can understand the results of the study. So if you see the different trials, there was realized trial, which they did with familial hypercholesterolemia patient. Then there was a defined trial where the patients with coronary heart disease or at risk for coronary heart disease were taken. And then we all know the REVEAL trial, where the patients with atherosclerotic vascular disease were taken. Now, if you see, the LDL cholesterol reduction in the realized trial was to the tune of 39.7. It was 39.8 in the DEFINE and 41% by direct method and 17% in a subgroup analysis of 2,000 patients. Now, HDL cholesterol increase was huge, 102%, 138, 104. If you see the non-HDL cholesterol reduction, it was minus 36, 31, and 18. ApoB 24.8, 21, and 18. ApoA1, it was 32.9, 44.7, and 36. If you see the lipoprotein A, 27, 36, and 25. Triglycerides, it was 5.5, 6.8, and 7. So if you see, there was a good reduction in the LDL cholesterol in patients who had hypercholesterolemia, patients at risk for coronary heart disease, and also patients with atherosclerotic vascular disease. And there was an increase in the HDL levels. So coming to the efficacy and safety as monotherapy or co-administered. So they found that it also reduced the lipoprotein lipase A levels by 50%, but not the CRP levels. So basically, when we are talking about the clinical trials, we know that we have different phase trials with this. And what they found that there was a dose-dependent change in the lipids. As I told that maximum effect was seen at the dose of 200. So people have now started using 100 in most of the trials. And they have tried to see either familial hypercholesterolemia patients or patients with patients at high risk of coronary heart disease. And they have tried to see the HDL change. And what they have found in this, that in the phase 1 trials, they say that there was a dose-dependent change in the lipids. And the peak effect, they saw that there was a 129% increase in the HDL cholesterol at 300 mg dose. And then they found that there was no effect on the blood pressure. This is very important because ILLUMINATE trial for the first CETB was abundant because there was an increase in the aldosterone levels leading to the increase in the blood pressure and increased mortality actually. Bloomfield, there was a phase 2 trial he did. It's hypercholesterolemia or mixed hyperlipidemia patients. And they found that there was a dose-dependent increase in the HDL cholesterol and reduction in the LDL cholesterol up to 150. And the Cannon et al., they did a phase 3 study with high risk of CHD. And they found that 0 or 100 milligram, the placebo versus the 100 milligram dose, and they found that the HDL increase in the anacetrapib arm was by 138%, and LDL cholesterol decrease was 40% beyond that seen in placebo arm. Now, this was one data which was published way back in 2010, when they found that anacetrapib treatment had robust effect on HDL, LDL, non-HDL-C, and lipoprotein with sustained effect over 18 months. As I told you, it gets deposited in the adipose tissue and it remains there for 1 year. And it has had an acceptable side effect profile with no effects on blood pressure, electrolytes, or aldosterone levels. And it did not exhibit at least the adverse cardiovascular effects which was seen with the prior CETB inhibitor. And the long-term safety, definitely they said at that point of time, that was way back in 2010, that we need to study. So after that, there were further studies which came. So if you see, this was one of the study where they have had around 1,623 patients. And the dose was 100 milligram versus the placebo. Duration was 18 months. And they tried to see the change from the baseline LDL at 24 weeks and also the safety. So what they found that LDL decreased by 39.8%, HDL increased by 138, and decrease of non-HDL-C happened to the tune of 31. So treatment was with anacetrapib when administered with statin. So this is important. Most of the trials which have been done have been co-administered with statin, led to a large increase in HDL and a significant decrease of LDL. And it did not result in adverse cardiovascular effects, because this is very important. Till that time, there was always the problem that there could be some adverse effects. So that was the thing which was shown that this drug does not cause. If you see the DEFINE trial, now there they had pre-specified adjudicated cardiovascular safety endpoint, that is cardiovascular death, non-fatal MI, unstable angina, non-fatal stroke, total mortality, heart failure, revascularization, and like PCI or coronary artery bypass graft. So there they said that it is a promising strategy to raise HDL and reduce the cardiovascular risk, but obviously not the mortality. And This was the NEGM trial. In this, they took about 30,000 patients over 50 years with occlusive vascular disease background with atorva 20 or 80 and randomized either to anacetrapib 100 versus the matching placebo. Follow-up was more than equal to 4 years and with more than 1900 primary outcomes, major coronary event like coronary death and myocardial infarction or coronary vascularization or stroke. And if you see the just a second. Yeah. If you see the this has come. So if you see the coronary death, myocardial infarction or revascularization, now if you see with anacetrapib and placebo, if you follow up and if you see this graph, now it did not differentiate till the time of 2 years. Now this was a study till 4 years. Only change you see has started coming after 2 years. So till 2 years, if you see both the placebo and the anacetrapib were almost going hand in hand. So this is over and above statin. Both arms had statin. This is what we have to remember. And after 2 years only, there was some change which was seen. Now, if you see the effects of anacetrapib in this study in patients with atherosclerotic vascular disease, this was HPS3 TB55 REVEAL study. So what they found that the death rate was not different. So what is important is among patients with atherosclerotic vascular disease who were receiving intensive statin. Now, these patients were already on a high dose of statin, that is intensive statin, atorvastatin, 40 or 80, and the anacetrapib was compared to placebo. So they found that there was a lower incidence of major coronary events than the use of placebo. So it did not reduce the coronary death, but the event rate was definitely reduced. And as we are seeing again in the graph, that the thing started showing up at least after 2 years. There was no effect which was seen till the time it was within 2 years. So what they said that there was a significant 9% proportional reduction in the major coronary events. Effect appears to be greater in later years of treatment. Very important because within 2 years, not much change was seen. Small reduction in the risk of new onset diabetes. No excess of symptomatic side effects with anacetrapib. Levels in the adipose tissue rise with continuous treatment. As I told you that these levels change and they remain for around 1 year because it gets stored in the adipose tissue. Important is there was no excess of mortality, but there was no reduction in the CV death. There was no cancer or serious adverse events. Small increase in BP was seen, but not much, which was not found to be statistically significant. So this is what is the comparison. They tried to see the other clinical assessment, that is the new onset diabetes. So it was less in anacetrapib arm as compared to placebo. So this was p-value of around 0.04. Difference was very minuscule, around 0.6%. Blood pressure, if you see, the systolic was mildly different. Like if you see, it was showing a change, but very, very mild statistical different, but though it was statistically significant. Hypertensive serious adverse events were not seen though. So though there was some change in the BP, but the statistical significance of the hypertensive serious adverse events were not seen. And as I showed you in the previous anacetrapib trials, that there is not much change or no change in the aldosterone levels as seen with the previous CETP inhibitors. Now, if you see the new onset kidney disease, new onset eGFR less than 60, it was in 1,344, which was found to be a little bit significant. But if you see the renal failure serious adverse events, again, it was not significant. There was no effect on vascular, non-vascular, or all-cause mortality, no effect on cancer, liver, muscle, cognitive functions, or other adverse events. Now, then, is anacetrapib better than its CETP counterparts? So, if you see the CETP inhibitors, others as compared to anacetrapib, unlike statins, anacetrapib actually decreases the risk of developing diabetes, which was not seen with the previous CETP inhibitors. Now, if the reduced risk of new onset diabetes is confirmed in another trial as well, this will be maybe a case for considering the use of this combination with a statin plus a CETP in high ASCVD risk people who are also at high risk of developing diabetes. But also we have to remember that there are multiple lines of evidence which suggest that HDL functionality is improved or maintained with anacetrapib inhibition. There's an enhanced macrophage to feces reverse cholesterol transport, which was shown in hamsters. Increased cholesterol ester content is seen, enhanced maturation from HDL3 to large HDL2, improved excretion of bulk cholesterol or bile acids, which was seen in again hamsters. Same thing has been shown in humans as well. Improvement in plasma cholesterol efflux capacity, no reduction in anti-inflammatory effect. Now, this is very important because there are some studies to show that, as I told you, CETP inhibitors actually mitigate the anti-inflammatory effect, the previous ones of HDL. But with anacetrapib, they have not seen any reduction in the anti-inflammatory effect. Improves the lipid profile without affecting the blood pressure. Though in the NEGM trial, we did see a small change in the blood pressure, which was very, very small, though significant, but it did not lead to any adverse event because of the increase in the blood pressure. Now, this was a study published in European Heart Journal where they found that anacetrapib reduces the progression of atherosclerosis mainly by reducing non-HDL cholesterol, improves lesion stability, and also it in a way adds to the beneficial effect of atorvastatin. Again, they have seen that anacetrapib reduces LDL cholesterol by inhibition of CETP, that is known. We saw the mechanisms, and reduction of the plasma PCSK9 level. So in a way also has some mechanism of action, which is like PCSK9 inhibitors. So what is the final take home? What do we need to do? So we know that till now, whatever data we have with the newer CETP inhibitors like anacetrapib, there is a definite reduction in ischemic events. What we saw in that NEGM trial, about 9%. The graph shows a change only after 2 years, not in the initial period. Though the CV mortality has not been shown to be reduced. So where are we? Addition to a statin may be helpful in some patients. It increases BP to some extent, so we have to keep this in mind. Stays in the adipose tissue for a long period. So that is why the effect is prolonged. And we also have to remember about the cost of therapy because it is going to add to the cost. Because when we are talking about statin treatment, we know that statin treatment is something which patients have to take because we have definite data of reduction of the mortality, CV mortality. But when we talk about use of anacetrapib or CETP inhibitors, we have not shown the reduction in the mortality. So still we need more data to definitely show that there is a reduction in the mortality as well. Maybe a long-term trial may answer that question because what we saw that the event reduction was seen mostly after 2 years, not before that. So maybe we need a longer study to show a beneficial effect of this drug. We have to remember that they have some effect on the BP, though this drug has a very minuscule effect as compared to its previous predecessors, but still we have to know that the BP change may have some bearing, so we have to keep that in mind. It works for a very long period, stays in the adipose tissue, so the residual effect may remain. That also we have to remember. And the cost of therapy may be added over to the statin. So whether it is justified, that is still a debatable topic. So with that, I end.